So hello everybody. We are live on YouTube, and though we still have some time officially for people to join, but we don't want to waste any time for 6 minutes extra for people who have joined earlier. With that, our topic for today is going to be home management. So we will be discussing in this rights of the doctors in various countries. What rights the doctors have, right, what rights the institutions have, what rights the government has. That is going to be our basic issue. We were listening to Deborah from Brazil, because Brazil after US now is number 2 in number of cases. And in number of cases, new cases, India is number 3. Not a good thing to have, not a good thing to boost. But yes, US, Brazil, and India now are in the top as far as new cases per day are concerned. And in India, we have at least 4 epicenters like Wuhan, Delhi, Mumbai, Gujarat, Ahmedabad, and Chennai in Tamil Nadu. And Delhi and Mumbai now are going towards a worse situation. We are seeing a lot of cases who are coming with silent hypoxia, and they are dying before the bed is being arranged. So at least 2 deaths I've seen in the last 3 days, and 1 death I could be able to prevent it last night. The patient had a oxygen level of 50, SpO2 of 50, and they were not getting a bed. So I said, go to the nearest hospital and be on oxygen till you get a bed. So I just got a call that throughout night they could be able to maintain his oxygen level to more than 90. The SpO2 of 50 would have died if timely oxygen was not given to him. So in India, we are seeing deaths occurring within 24 hours of hospital admission. So whenever there are deaths after 24 hours of hospital admission, we look for the hospital infrastructure. But whenever there is a death within 24 hours of a hospitalization, we always say your primary care is not effective. That means there are deficiencies in your primary and emergent care. Normally, death should not occur within 24 hours in such a situation, because most of such situations should be able, that means patients came late. That means patient ignored his symptoms. So that's what we are going to talk today on home management of Mari from Japan also have joined. Thank you, Mari, for joining. We still have some more time for people to join, but the topic today we are discussing is home management, whether countries allow it or not. Because now, for example, in Delhi, there is a recent study which has come from China, and the study is they had 6 new cases. China had 6 new cases. Yes, Jamal, how are you? So China had 6 new cases, and they tested 6.5 million people. Can you imagine? So they tested 6.5 million people in 14 days.
Yes.
In 14 days. And they detected 200 people who were asymptomatic positive, and they cured the virus from their Wuhan again. Because now there is no case. They isolated all 206 patients. So one thing which comes is every country start looking for, wow, can we do it? We can't do it. But there is a hidden message. The hidden message is for every 1 positive case, there are 33 hidden cases. The message which comes is for every 1 confirmed case, there are 33 hidden cases. That helps us now in the statistics, that number of people we are dealing with. So in the city of Delhi, if you have 1,000 people detected positive, the number actually may be 33,000.
Oh.
The number actually may be 33,000. In Brazil, you had 30,000 new cases, actually may mean 100,000, maybe may mean even 1 million. In India, you had almost like 10,000 cases. It actually may mean 300,000 cases yesterday. So for the say one way it is good. More the number, less will be the mortality. One way, if the number is very high, and the mortality, because it will now reduce the mortality. So one way it is good. On the other way, it tells us our preparedness. So therefore, in this season, every patient who is cough and cold to be taken as corona. Now, what is happening is, in a family, there are 5 people, all get the same symptoms. There are 5 people, all of them get the same symptoms. One of them will get tested. If he is positive, the rest 4 will not go for testing because they don't want to spend money. In India, government is not doing testing of everybody. So therefore, privately, if you go for a test, it costs 4,500 rupees, which is equivalent to, say, how much it comes out to be in dollars? Something like $50. And if everybody has to give it to their family, so they say, see, one testing, we presume rest 4 are tested. They are positive. So therefore, there will always be under-reporting of the cases. Even symptomatic cases will be underreported because in one family, suppose you have an office, all 11 of you have a viral-like illness. One of them is positive, rest and you will just manage it like that. You will presume it is virus, number one. And number two, you know that 33% the virus may be negative. You are having a false negative test. So therefore, reporting does not give you the actual figure. Reporting by the testing and reporting by the government actually does not give you the correct figure with that. That's the reason we are actually showing a large number of cases in various countries with that. Now, if I say Bangladesh, if I see Bangladesh, in Bangladesh, we have 2,828 cases yesterday. And Bangladesh population is 1.16 million. It is 16 million. And so actually speaking, these 2,228, depending upon the density, if you are maintaining social distancing, things are different. But if you are, say, we compare China with India because our density is the same. And I don't think so Bangladesh density will be different. Bangladesh, China, India, Pakistan, density of people per square feet, per square kilometer will be the same. In that situation, in Bangladesh also, we might be getting a large number of asymptomatic cases, unless you do like China and test everybody. Unless you have like China and test everybody. Arasu, you want to comment on this?
Of course, I think COVID, one thing that has taught us that every country, like for Malaysia, I think what we have done is that we have used, based on our limited resources, what is the best approach for the country. So our approach is, of course, the test is not done throughout the whole country. It is more into focus group testing. That's what they have done. And they find it is a bit more effective than just test out everybody. Unless you have the resources to do that, then it's fine. I think currently our testing capacity, public and private, I think is close to 25,000 a day. So of course, when they do the number of samplings, but so far we managed to contain very well. Our cases are going into a single digit for Malaysians, for Malaysians. And the reason the increase of cases were actually in the detention centers of illegal immigrants. And then in terms of social mobility, I think more businesses has opened up. And then social distancing is being, I would say that is being observed by even the Malaysians. We can notice that in the restaurants and also places where they're quite stringent. And then the application, the government has also launched an application, mobile app last month, whereby I think they have more than probably 1 million plus have downloaded so far. And then that gives us updated information. And one thing that government is using is the Disease Prevention Act 1998 to enforce, especially on the screening. That means it gives the authority for the government to screen, because this is classified under one of the infectious disease, COVID-19. So that gave the power to the enforcers to enforce certain things. Like, for example, they've also given a strict order to the companies. If they find that there's a cluster of cases, they'll shut down the company for 2 weeks. So that actually has caused companies also to take up own responsibility to test. That can be observed in the construction industry, where the construction industry, there is a profession, there's a body that controls it, that monitors that, regulates that, and they made it very strict. If the construction industry, if their workers are not screened for RT-PCR, they cannot they cannot go to business. So that has prompted many of them to do the testing, and then from there they also have managed to get a lot of positive cases. So far, we would say that approach is working quite well in Malaysia, and of course there's lots of resistance. There's resistance also from certain places, certain professional bodies where they said the MCO may not really work. But I think so far Malaysia, we are quite happy. As Malaysian Medical Association, we are quite happy with the Ministry of Health of Malaysia on their approach. And then things are working quite well in terms of managing COVID.
Thank you, Arasu. Let me also welcome Dr. Sanchita Sharma. She is the editor of IJCP Group. We have Dr. Prakash joining from Nepal. We have Dr. Pillai joining from India. He is the council member to WMA. And we have Dr. Sajjad from Pakistan also joining. So I'll pick up 7 or 8 situations. Dr. Russell from Australia and the bioethics chairman has also joined. And Mary is already there from Japan Medical Association. So I'll pick up a few situations. And I'd like to make some consensus statement today on behalf of the CMAAO. The first situation is that in India, a pilot, an air pilot, took a flight to Russia. On the way, he was found that he is COVID positive, and the flight had to be returned back. And after that, there has been a new Government of India policy. And the policy is no international flight will take place without the pilot, the crew members being tested negative. That means every time you have to fly, every time you are a crew member, you will have to give a nasal swab. And if your nasal swab is negative, you are boarded. When you come back, go to the next flight, again get the test done. Now, my first question is this the policy in other countries also? B, pilots are equivalent to ICU doctors. There is no difference between pilots and ICU doctors, intensive care doctors, because in an intensive care also you are taking the seeing critical patients, 1. 2, the plea given by the government is that if pilots can co-infect other crew members, and we have shortage of crew members. Remember, we also have shortage of doctors in the country. So should doctors also be tested? Should there be a right for the doctors to know their status before going to a COVID ward? This is my question of the day, that if doctors want, if they are posted in a COVID ward, should they have a right to get themselves tested? And if they are negative, then only they go to a COVID ward. These are the 2 things which I am going to take. We always have Alvin, who has joined us from Hong Kong. And so I'll take opinions from everybody. A, do we have a consensus in any other country where before flying international flights, the crew members have to be tested negative? B, do we have a policy in any country, in Asian countries, that any doctor who goes to a COVID ward has to be tested negative first. Or any, yes.
Can I just ask the justification of the, can I just raise a question, Dr.
Yes,
Aggarwal?
please.
You were just comparing the situation in the aircraft and the COVID ward. So in the COVID ward, actually,
No, not
all
COVID
are
ward, any hospital. Let's take
any hospital. Any hospital. That's
Any
a different issue.
Yes,
That's a
any
different
hospital.
issue. That's a
Because
different
your
issue.
situation is the same.
Yeah. Yeah.
So
Yeah.
if I am going to a hospital, do I have a right? Suppose you say I have a right, so I should say after how many days of my duty, I should get myself tested. Maybe you make that if you have done 7 days duty, you should yourself get tested before you join again. I mean, it's a hypothetical question based on what is happening in the air policies. Because in India, doctors are not allowed to be tested unless they have symptoms. So if I am a doctor, if I want to get myself tested, the government will say, no, we will not allow you to be tested unless you are symptomatic. I may be asymptomatic, I may be pre-symptomatic and cross the infections to others. So the policy for a healthcare worker should be that after every 7 days of duty, they should get themselves tested. It's not a blood test, it's just a simple nasal swab. They should be tested.
May I share the
yes, please.
May I share the experience of Bangladesh just shortly? In Bangladesh, actually, we started as China, they have done it. It was 10 days work, 14 days quarantine, and 6 days in the home. So now we are just rescheduling. This is actually we're proposing now 7 days work and 7 days quarantine. And within this time, he will go for testing. And then if he is negative, then he will be allowed to go to home. And after another 7 days, he will come back to the work. This way actually is to be followed in Bangladesh, because we think that working in the COVID hospital, if he is getting positive, then he cannot go to the home. So that is why
again go back. This is for the doctors.
Yeah, this is for the doctors and the other personnel.
No, tell me for the doctors again. If you
that is a 7 days work, and then 7 days in the quarantine. Quarantine means in a hotel we are keeping just now, but I don't know whether it will be possible in the near future. And then another 7 days they will go to the home to be with their family if he is tested negative within this time.
Okay, so you are talking about it in 21 days, only 7 days work.
Yeah. Yes.
And then testing will be done on 14th day.
No, not 14th day. This may be just on 10th day, like that.
Okay.
Yes.
Okay. What about in Malaysia? Do we have a policy like that?
In the public sector, they do test those who are directly involved in the testing. And then they do have an occupational health department where they monitor all those who are directly involved in the sampling and also treating the patients very stringently. So that is why the main hospitals that has been COVID hospitals, they didn't have any cases of infection among the healthcare workers. Very stringent.
What about in Hong Kong? What is the policy? Hello. Elvin, are you there? Okay, he is not there. What about in Nepal? What are we doing? Can you unmute yourself?
Yeah. In Nepal, we have a 7 days duty. Then after that, they will go for the 14 days quarantine and 1 week home quarantine. But there is no actually the testing. But they are telling that if they are feeling that they are exposed to the patient without PPE or other reason, then only they will allow for the testing.
So 7 days duty, 7 days off. And during these 7 days off, if you don't develop symptoms, because the incubation period is 5.2 days, you come back to work.
Yeah.
Okay, good. So in Brazil, what are you taking in Deborah? In Brazil, what are the guidelines for the doctors to work?
Yes, in here we have the passengers are tested. If there are some symptoms of coronavirus, they don't travel, and they will send to the hospital or to the doctor to examination. And there are a few flights in a day, but the notes that it will be returned in this month. At this month, they will return to fly to Europe, to France. It didn't stop, but a few flights a day, less than it was before the pandemic.
Good.
And here, but here we don't know when we will stop the pandemic. Here is a big problem because our country is bigger, very big.
So what about Dr. Pillai? What are you doing in your hospital, in a private hospital in Kerala? After how many days are you testing your residents? What is the policy in a private hospital in Kerala?
Thank you, KK. As you well know, here the situation changes from state to state.
In Kerala, in your hospital. In Kerala, in your hospital.
Yeah, here what we do is that
Your voice is not coming.
Yes, good afternoon.
Dr. Subramaniam, how are you?
Fine, thank you, Dr. Aggarwal. How are you?
We are fine.
Now,
yes, go ahead.
till today, the private sector in Kerala, we don't have any COVID patient. It's all managed in the government sector. So the private sector, so far, we don't prophylactically
so
test for doctors or healthcare workers. But the government sector, of course, symptomatic. If not symptomatic, then as has been said, 1 week quarantine. They work for a week and then 1 week quarantine. So that's what is happening in Kerala.
Thank you. Thank you, Dr. Pillai. Dr. Sajjad, what is the position in Pakistan? You have to unmute yourself.
Yes. Can you hear me?
Yes, Dr. Sajjad.
Hello?
Yes. Kindly go ahead.
Okay. Actually, in Pakistan, what we are doing, particularly the doctors and the paramedics, those who are performing their duties in corona patient, with the corona patient, what they do is they do a 7 days duty and then 14 days quarantine. After that quarantine, if anybody feels develop any symptoms, then they will go for the test. Otherwise, after 14 days, they will come back again to the duty for 7 days. This is what we have the planning, and between that, if after having a quarantine 14 days, if he wants to go to home for 4-5 days or 7 days, he can allow, and in place of him, the other doctor will perform the duty for 7 days.
So there is a standard formula in Asian countries that in a government COVID hospital, you work for 7 days, then 7 days quarantine, and then you come back if you don't develop any symptoms, based on the assumption that you have the incubation period average is 5.5 days. I would like Dr. Russell to pitch in. Dr. Russell, I want to take one more question. I want to pick up is, do we have some guidelines from UNESCO? You might have had a seminar on that. Doctors' rights during COVID era. I'm not talking about in general doctors' rights. I'm talking about doctors' rights in COVID era outside the government sector, because government can put their guidelines, but private doctors who are in practice, we are encountering a large number of influenza-like illnesses. Now it is opening up. Doctors are allowed to work. And if you are working, if I am working, then I'm bound to get asymptomatic cases. So are there any guidelines about doctors' rights?
No, we haven't.
Just my best. Why I am asking this question
Yes.
is because if I have come in contact with a COVID positive case, but I am not symptomatic, do I have the right to ask for a test? A. B. If a patient today comes out to be positive, and if he happens to be in a home quarantine protocol, which is happening in India, home quarantine means that you can isolate yourself in home under supervision with
in a single room,
in a
separate room. In a separate room.
if you are alone, but if you are husband and wife, both of them are positive, they can be in the same room.
Yes.
So if you see, there can be, suppose in a family, you have 5 patients, all of them are COVID positive, then single room is not required.
Yes.
And they need to isolate you need to isolate COVID positive from COVID negative people. So, but not 2 COVID patients, they can be together.
Phone.
Yes. So therefore, I need to know, are there any doctors' rights policies written for Asian countries or Asiana countries?
Not to my knowledge. Not to my knowledge. We did have some discussion about these initially when we had a combination of David Bob and Otma, all of them. We put something out, I think, some months ago. But what you're talking about is now that you're coming out. This was when we started at that time. What was because there was a question. There was something in UK where one of the professors wrote that it's ethical to refuse to teach to treat, and the WMA opposed that. They actually from the BMA, there was a person who actually wrote an article that said it was ethical to refuse to treat if you didn't have the PPP and all these other things, and so that was a big discussion. So we came out with something at that time. But what you're saying, I think. Again, this is going to be different. In Australia, getting the test, everyone's expected to even to go and get the test done, even if they're in contact, if they are working in the hospital, even without symptoms, they are advised to go and get. So I think that's a little bit of a complex area in terms of putting out something. But what you're saying makes sense because we have moved to a different phase in the last 3 months that this has happened. So I think maybe we should bring something out like that, Dr. KK, from CMAAO, isn't it, for the Asian region?
I agree with you because we need to have some rights of the doctors today. We need to save ourselves. We need to save our families. See, if you are allowing an air pilot, if you are not quarantining an air pilot for 7 days after a flight. I mean, after he does a duty and mixes with 200 people, he is tested every time. So why can't a doctor be tested every time? So I'm putting it open. It will be country to country. In various Asian countries, let me summarize. We have China, where 6 people were positive. They tested 6.5 million people in 14 days. That's one level. Within the same Asia, we have one level. Second level is New Zealand, no new cases at all. Second level is New Zealand, and then comes Australia. Practically, they have been able to take care of that. On another level, we have Delhi, Mumbai in India, where you are practically in phase 4, where now the importance is no testing. In phase 3, you do test, and in phase 4, Only in phase 4, you say no testing is, what is the use of a testing? And that's what it looks like, because government is saying, why testing? Why do you want to test asymptomatic patients? That means government has accepted we are in a phase 4, treat everybody as positive. Why do you want to test? So in that particular situation, we really need to understand the rights of the doctors at from various countries level, so that we can come out with the common rights for the doctors of the Asian countries. At this moment, at least in India, we are confused. We are confused. The private doctors are confused. The government doctors are not, because they are dictated by the government policies. But as a private doctors, you are confused. So yesterday in Delhi, government said we will charge sheet those doctors who are sending asymptomatic cases for investigations. They have charge sheeted 8 laboratories on the grounds that why are you testing asymptomatic patients? Because the positivity rate in Delhi was 38% in many districts. That means out of 100 testing, 38 were coming out to be positive. So they said, stop doing it. Why do you want to test? Why do you want to create a fear in the mind of the people? Treat everybody as a cough and cold and a positive COVID and treat it. And if that happens, there will be no isolation, no quarantine. If you're not going to do a test, nobody will go for a quarantine.
That's
Nobody.
right.
Yes. Yeah.
Everybody will say, why you are putting me out of job for 14 days if I'm not positive? So that's what we thought of discussing today, so that we can actually come out and understand, because now Malaysia says that, Kerala says you can't treat it in a private sector, which is fine. But because the situation in Kerala is different, there are very few cases. If you have 30,000 cases occurring in a day in a state, I think government can't pitch in. Even if they have 1,000, every day you have 1,000 cases, that is symptomatic and that is positive cases. It will be difficult for the government to do it without the help of a general practitioner. Yes, how are you, Chong? So you are not driving today. For the last 2 weeks, he is not driving. He is on 2 weeks duty, 2 weeks driving duty, then 2 weeks off in the home. Quarantine in the office. Dr. Chong, we are talking about, are there, in the COVID era, are there any rights of the doctors, specifically of the private sector? When I say rights, means rights to tested, rights to refer, rights to give opinion. That's what I'm talking about. Say, for example, the issue which has come in India is a doctor who is asymptomatic, even if he has come in contact with a COVID-19 patient, will not be tested unless he develops symptoms, which I think is wrong, because there is a reaction among the doctors. So we wanted to know what is happening in other countries.
In Bangladesh, can I just tell?
First, let Dr. Chong answer.
Oh, okay.
In Singapore, I don't think we have much of this kind of issue in the sense that if we are very criteria driven. So if you are exposed to a patient and you need the swab, they'll do it. That's it. You know what I mean? It's all very criteria driven. It's nothing to do with individual rights or whatever. If you fit the criteria, we swab you. If you don't fit the criteria, we don't swab you. Right? So if you have fever and you've been in contact with a COVID patient, if you're worried about being infected, and you're a healthcare worker, will definitely swab you, right? Because your healthcare resource is very important to keep you intact and so on. So in Singapore, we don't have such problems.
So that's what I'm saying. The written document in India is that if you are a healthcare provider, if you have no cough, fever, and breathlessness, even if you are exposed to a COVID-19 patient, no swabbing.
No, I think that's wrong, because you should be swabbed, because we know there's pre-symptomatic phase, right? We know there's pre-symptomatic phase, so you should be swabbed. As long as you're a healthcare worker, I think you should be swabbed, because very simply, we have to protect the healthcare resource.
Absolutely.
Yeah, so in Singapore,
Dr. Subramaniam, he has joined, I think, for the first time in the meeting. Can you speak up? Can you unmute and...
Well, in Malaysia, our situation not very different from Singapore, but what we are doing, our numbers are coming down. Definitely our new case numbers are coming down. And yesterday there was only 19. Now, do they have to screen everybody? Healthcare workers are all being looked after, screened, make sure they are not in danger. GPs are allowed to screen patients if they suspect. But the whole system, they have actually tried to create a situation where there will be no spread of infection. The clinics has to be arranged. You follow all the SOPs that has been developed by the country.
So why I'm asking this question is 8 laboratories in Delhi yesterday, day before yesterday, were terminated. They cannot do the testing because they have tested people who were asymptomatic, and they found them, they were positive. So they said because you are detecting asymptomatic positive persons, they were given a show cause notice and they were debarred from doing the testing. So Elvin, are you there? Yes.
Hi, Mr. President. Just now I could not find my the mute sign, so I could not speak up. Sorry for that. In Hong Kong, I think the situation is just similar to that of the Singapore, and in fact, there are no patients for the almost 1 month, and then resurgence of the finding of 4 confirmed cases in Hong Kong just in 1 day. And so, in fact, we have to do more testing for the deep throat saliva from the GPs, from the private doctors. And however, the problem is the logistic problem, and it's not user-friendly. And the government cannot make it mandatory. It is too much. But then we are only doing 2,000 tests a day, which is far less than adequate. So we expect at least 10 times of such testing, at least 10,000 testing a day. That would be much better. For the doctors, because we are facing asymptomatic patients all the time, it's easy to get doctors to be infected. So we urge doctors to also get tested if they feel anything suspicious of themselves. And there's no problem for doctors to be getting tested. But then it's the label or stigmatization that the doctors, they fear that they rather won't test it, because even if you are asymptomatic, you will be found positive, and then the whole world know that you are positive. Then many doctors want to avoid that, you know. And so that's why many doctors are reluctant to get tested. Rather, everybody would be very prudent in putting on level 3 face masks and PPE, especially in seeing symptomatic patients, I mean, fever or cough. And then even though they perhaps just flu or perhaps just a rhinovirus or other allergy, they will still put on a full gear in seeing patients. So, and with such a full protection, fortunately, in Hong Kong so far, we still have no health medical personnel being infected in a hospital or clinic setting. But unfortunately, of course, recently there is an ambulanceman who was infected in the ambulance by a patient. He had just put on a level 1 or 2 surgical mask at that time, and then he got infected. So we urge all the ambulancemen and also frontline doctors at least to put on a level 3 surgical mask, or for the doctors doing ICU work or intensive care or other infectious disease works, all will be putting on an N95 mask. And that's the situation in Hong Kong. Thank you.
So I want to put one more. I want to put one more final question, which will have opinion of everybody and try to bring in a consensus. Delhi, Mumbai, we are seeing a surge, and the surge is showing certain findings. A, immunoinflammation in Asian countries is not that significant as in Europe. So we are not getting that COVID toe, we are not getting Kawasaki, we are not getting hyperimmune syndrome. In both the places, we are getting very high numbers of silent hypoxia. In both the situations, we are getting very high level of silent hypoxia.
Aggarwal, can you increase the volume? The voice is, please increase volume, please.
My volume is, मेरे को जोर से बोलना पड़ेगा.
अच्छा, okay. आवाज कम आ रही.
You can remove that mask. When you put the mask, you are not heard well.
Yes, maybe.
Face shield.
Face shield.
Because we are two people sitting within a distance of 3 feet, so I started using the mask.
Right.
So what is happening is that a person will develop fever. The fever will disappear by 6th or 7th day. Now compare it with dengue. Now I'm trying to compare COVID with dengue. Fever settles, and suddenly there is a capillary leakage in dengue, and you become serious on day 7 or 8. Imagine COVID-19. You are okay. Fever disappears. Suddenly there is an endothelial dysfunction, and you develop hypoxia. Therefore, hypoxia develops on day 7, 8, or 9. Usually, hypoxia and fever are not together. Very few cases you will get people who are silent hypoxia and a fever together. Now, if you develop a silent hypoxia on 7th, 8th, 9th day, suddenly there is a hyper immune response. You become hypoxic to the extent that your oxygen level may be 50, 60, and if you are not treated in time, you die. So I want to make a hypothesis based on the findings from Asian countries that the triggering factor in COVID-19 is hypoxia. That means after the fever is over, don't neglect yourself. Go on checking your SpO2 monitor. At any given time, if your SpO2 level falls to 60, 70, 80, and you are a silent hypoxia, and if you can be started on timely oxygen, you buy time. In India, in Mumbai, ventilators like Italy have not been able to save lives. Even in Italy, we saw that. In Italy, we saw a strange phenomena. People were coming, putting on ventilator, people were dying, and a day came, there were no ventilators available. Because no ventilators were available, they started treating them with conservative oxygen therapy, and the mortality rate reduced. The mortality rate reduced in that particular situation. Same phenomena we are seeing in Mumbai. And we just got the chairman of the COVID task force in Maharashtra. He just wrote to me that ventilator has not helped us in reducing the mortality. It's oxygen, 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 and oxygen. So I want to propose to all my Asian countries that the earliest level, if you can pick up hypoxia and start oxygen at that particular moment, maybe you will prevent and reduce the mortality. So we were looking for one parameter. What is that parameter which can gives you the point where there is sudden worsening? See, always person likes this and suddenly worsens. So we are looking for that point of no return. People talked about it is D dimer, somebody said it is ESR, somebody said HSCRP, but that testing, you cannot get it done every day. So the clinical test is hypoxia. You have hypoxia, start oxygen, give him low molecular weight heparin, then arrange for a bed. Instead of, because if you arrange for a bed, you may take 6 hours, 8 hours, 12 hours. One of my patients, yesterday, 5 o'clock in the evening, he's looking for a bed. Still, he hasn't got it. He is on the, I only arranged a oxygen concentrator, 10 liters. He is on oxygen till the bed is created. So therefore I say is a COVID hospital is a oxygen concentrator with and without high flow nasal cannula, with a oxygen monitor till you get an ICU bed. Whether you do it at home or anywhere, you may be able to reduce mortality. That's my assumption. So is oxygen, sudden hypoxia, sudden fall of oxygen is the point of no return. Point of no return means sudden deterioration. Is it the point of sudden deterioration? This experience I have been studying. We saw them in Italy. We saw them in New York. I talked to my brother-in-law. He is in New York. And he says exactly the same we follow. The same thing we have studied them in Mumbai. Same thing we are seeing them in Delhi. 2 patients I lost in the last 72 hours. After their death, I came to know they had sudden hypoxia. They started looking for a bed. 5 hours, no bed available, and they died on the way. One by one, I would like to, this is my last question. One by one, I would like to take opinion and come back with a consensus. Is hypoxia the triggering factor? Anybody can raise hand?
Yes. A similar situation we have observed in Bangladesh also. And just we have started that protocol actually, just to avoid the ventilator actually. And the high flow nasal cannula is just doing the things. Of course, in Bangladesh, it's a very scarce actually. We are trying to procure it now, the government, from the government level, and they are trying it.
Dr. Chong, then Dr. Chan.
Dr. Aggarwal, it's very interesting. In Singapore, you know, we have a big outbreak in the dorms. That's why you see me driving on Saturdays. Is actually I'm on the way to the dorm, on my way back from the dormitories. That's why I've been driving. So because we usually do our dormitory visits on Saturday mornings or lunchtime. So the other thing is that we've been issuing pulse oximeters to all the dorm workers to monitor twice a day. So this is our protocol in Singapore. We give a portable pulse oximeter to the dormitories, and they monitor everybody twice a day for SaO2.
And if the SaO2 falls, then immediate oxygen.
SaO2 falls, ship them up to the hospital immediately. You know what I mean? So we tell them the guideline is below 93%, ship the guy out.
Okay.
Yeah, that is our guideline.
That's what I'm talking about. I'm only adding is till he's shifted to the hospital, put him on the oxygen and then shift. Because in Singapore, you may be shifting early, but in India, shifting means 5 hours.
Yeah, that's right. So we've actually distributed like hundreds of thousands of pulse oximeters to all these workers. So that's what we are doing. That's
a good recommendation. Dr. Chan, you want to say something?
Yes, our situation in Hong Kong is similar to that in Singapore, although we don't have the outbreak in the dormitories for the overseas workers. We have very few patients, that's true, but then we have some quarantined people, contacts with those patients or coming back from overseas. Those people, we would give them some oximeter. And but fortunately in Hong Kong, we never had any cases of drop dead due to hypoxia. But rather for the recent episode of outbreak, the cluster of patients in the same building, we are worried that in fact it's the exhaust fans, and also worry about the utensils for eating. They could be carriers of the viruses from the patients. And that's something that we are searching for, the chain of infection for those cluster of cases. we are worried about a second wave due to a super spreader with such exhaust fan as a common portal of infection. But for the hypoxia episodes, fortunately we don't have in Hong Kong so far. Yeah, thank you.
I'll ask now one by one because we are now only 12 minutes left. I'll ask first Dr. Sajjad from Pakistan to talk about your experience about hypoxic phenomena in COVID. And then Prakash, Dr. Sajjad. Kindly unmute yourself. Kindly unmute yourself and speak.
Okay, thank you. Actually, we have mostly the cases of hypoxic cases in Pakistan who needs oxygenation, and we have a center here, and we call it isolation center, where there is no HDO or ICU. Only we manage symptomatically, and the oxygenations through that the patients recover in hypoxia. If they required for HDO, then we refer to HDO or ICU.
That's okay. Thank you, Dr. Prakash.
Thank you, Dr. Aggarwal. In Nepal, luckily we have 98% positive are the asymptomatic. They are discharged without any intervention, and only few they have a maximum. They have a malaise, and some have a fever, and some have a dry cough. But they are not needed any intervention. Also, just the symptomatic management. And till now, we have not got the death from the corona as before it was diagnosed as a COVID. Once the death is occurred in the quarantine or somewhere in the midway, then we took the swab from the dead body, then that was diagnosed as a corona. That's why we don't have such a hypoxic condition in the patient, and we don't have the such experience. But it will be noted, and we try to impose in the government guideline.
Thank you, Prakash. Can I have Mary? She hasn't spoken till today. Mary?
Thank you, KK. There are very few reports about hypoxia. I think this is the reason why is we are now being able to follow up with those who are without symptoms and mildly ill patients. So they are checking 3 or 4 times a day with oximeter to O2 saturation level. And if it decreases, of course, we are sent to the clinical care, ICU care. So yes, there are very few cases reported. And I would like to another thing. The paper you, the KK distributed yesterday, I think, about the treatment with hydrochloroquine and azithromycin. The report was withdrawn. So, and only in Japan, there are only 30 cases has been treated with hydrochloroquine, but it was very good. The results were very good. Are there any plan of using the hydrochloroquine plus azithromycin in CMAAO countries?
We are using as a routine. Hydroxychloroquine is used in every case. People are choosing between azithromycin and doxycycline. Some people are using azithromycin, some are giving doxycycline. But
so
every doctor is taking hydroxychloroquine 2 tablets a week.
Oh, so what is the impression of the usage of these?
At this moment, the recommendation of the government is don't discontinue, continue chloroquine. We are getting encouraging results. They have not yet declared what does that encouraging means.
Okay, thank you.
Thank you. Ravi, I want to have Ravi and then Gana Bhaskaran, and then I'll ask Dr. Chong to sum up.
Sorry, KK. I just came in. I'm not following. Can you just bypass me and let the next person talk?
Okay, Dr. Russell, you want to add something before I ask Gana Bhaskaran and Chong to enter?
No, KK, I'm just listening to everything, nothing to add here.
Thank you. Gana Bhaskaran, we started before the time, but now you need to give up your remarks. He's the president of Malaysian Medical Association. So COVID has given him extra 3 months of pregnancy to nurture Malaysian Medical Association. Yes, Gana.
Yeah. Can you hear me?
Yes, we can.
Okay, good. No, the main issue, I think everything has been spoken earlier by our Arasu, my secretary. I'm still in a situation where I'm saying, is there not a common standard of SOP? Like what secretary say, every country is different from its from how you take control of this COVID-19. But isn't that being able to come to a certain kind of decision? You know, because everybody is talking about the vaccine coming soon. Yesterday I read in the paper, China is already nearly coming to the human study, and it may be coming out by end of the year. Is there any indication at all who will be coming out first? India also, I know there's one factory, one of your big guys in Patna or Pune was trying to do this. And is there any chance that something is going to happen soon on the vaccine?
Even if the vaccine comes, we don't know how effective it will be. So in any way, when the vaccine comes, it will take another couple of months, but we still don't know how effective it will be. Will it be able to reduce all the complications or not? So the Oxford group, there in India, every company who is coming in association with a Western country. Like we have a Oxford vaccine, which is a adenovirus chick vaccine pitched with the spike of coronavirus. That is at the moment showing some response, and a messenger RNA, which is a reconstituted RNA, is showing some response. So let's see what happens.
Thank you.
Can I have now
Dr. Aggarwal, can I ask you a question?
Yes.
Yeah, in a way, you asked about the rights of doctors. In Hong Kong, that's a particular situation. And I just want to ask all of you your opinion. In Hong Kong, the young doctors especially, they are very, very worried about the national security law that had been passed in the Chinese central government, putting Hong Kong into the governance of the mainland government. All right, anyway, so those young doctors have been very, very upset. And then many other professions, including lawyers or other professions, they are asking for a strike for their profession to demonstrate their opposition to passing such a law. Now, those young doctors might also be participating in a strike like that. That is, if they leave their positions in this COVID-19, disaster, and the trouble of not enough medical workers already. So if some young doctors still go on strike, would you think that would be sympathetic? You think we should be sympathetic, or we should advise against that, although they are exercising their rights as a person or as a citizen? But what about us doctors? Do you have any opinion, Dr. Aggarwal?
Dr. Chong talking about this?
Dr. Chong, I'm sorry, is that Alvin? Is that right?
Yeah, it's Alvin, sorry.
Alvin, is it they want to go on strike on what grounds?
They want to pressurize the government or let the whole world know that they were angry, frustrated, disappointed. Okay. All right. They just want to express their opinions, but having a strike that might jeopardize the benefits of patients So as doctors, we should put patients in the first priority. Many of the older doctors in Hong Kong would think that way.
Yeah, I guess the reason I asked that was because earlier, when we had the program, the webinars, we had one program with the WMA president-elect, secretary, treasurer, the whole lot of them, and the British BMA. That was not similar to what you're saying. The issue was about protective gear and risk. And so someone said it was if they didn't have, it was quite ethical to refuse to treat. And the WMA, they said that we can't do that because when you join, so it of course it's totally different to what you're talking about in Hong Kong. There the explanation was that when you joined to be a doctor, you knew that there was a risk, and so we can't. So that was a different thing altogether. It was about the risk. So a soldier going to war, where he knows that when he joins the army, whatever it is, he'll have to fight. So this was what the WMA team gave in response to what the British medicalization, the ethics chief and others were talking. So I'm just repeating that. But from your perspective, it's a different thing altogether, where you're talking of rights and so forth. It's probably different, yeah.
I think Dr. Chong can make a note on this, send it to us, we'll circulate it to everybody. Come out with
Dr. Aggarwal, can I raise a point actually? Because today, before roundup, actually today, was it there was an agenda for home management of COVID-19. And so I thought that actually advising home management of COVID-19 and it is actually whether we should advise the patient having COVID-19 patient with pulse oximetry and pulse oximeter to keep pulse oximeter with them.
About home management is if a patient is mild, if a patient is asymptomatic, pre-symptomatic, very mild, corona positive.
Aggarwal, can I speak?
Just I have not finished actually, because I had a patient actually. That patient actually was having only fever for 1 or 2 days, and after the day interval, she developed severe hypoxia. It was then she had to be shifted to the hospital at midnight. So actually, I have seen the guideline which is published by the WHO on latest 3rd edition, 27th May, that they have written that it's not mandatory or it's not advised to keep pulse oximeter in the home. What is your opinion?
It is not advised to keep pulse oximeter at home. No,
they have advised. They have not guided. Actually, the WHO says. WHO says that at home. I'm sorry, not getting you.
Without pulse oximeter, you cannot manage a case. We are recommending every case
in home management.
No. In home, unless you have a pulse oximeter, how will you come to know that you are becoming serious?
Yeah. That is my question. Actually, I have seen it in there.
And this is what Dr. Chong also said. They have distributed millions of pulse oximeters. Everybody.
Yeah.
If you have a blood pressure monitor, you should also have a SpO2 monitor. And if you feel, see, I tell my patients that if you walk and your SpO2 falls, or if you walk or talk, if your SpO2 falls, that is the earliest sign of hypoxia.
Yes.
Resting hypoxia comes later. So I tell my patients, walk every day in your house, and on walking, if your hypoxia develops, that's the time to start oxygen and then call your doctor where to go. I'm only talking about is that by taking home oxygen, you are buying 4 to 5 extra hours before you get admission. That's what I.
Aggarwal, can I ask some one questions to all of you?
Yes.
how many doctors are expired in COVID in your countries? Everybody.
So I would say let us compile a list of all the doctors who have died in our Asian countries, and like America is doing, they're putting a homage in their American Medical Association site. The CMAAO countries should do the same. On our CMAAO website, we should have all the lists, and we should pay homage to all the people.
Yeah, yes. We have 22 cases actually of death. 22, but not all of them are associated with the COVID-19 patient treatment. Actually, they are
especially the COVID-19 particularly.
In India, no. Can you give the figures, Dr. Mathanda? In India, how many doctors have died? Dr. Pillai, I think he is. So we will take it up next time. We will ask all the medical association to submit the data. Let's talk about making a resolution and sending it to everybody. This is now exactly 1 minute left. I'll request Dr. Chong to propose a vote of thanks, sum up and propose a vote of thanks, and invite everybody for a cup of tea in their respective places.
Thank you, President. Just to summarize, I think I came in a little bit late, but today we were talking about ethics versus criteria when it comes to swabbing of healthcare workers. I think the issue here is really access of the healthcare workers to swabs. And it's come across that some countries, for example, like India, there's some issues with ethics, whereas most other countries, we're just still going by criteria and the need to protect our healthcare workers. Second thing we talked about was silent hypoxia. Now, silent hypoxia is quite the enemy, and even in Singapore, for example, there's been huge distribution of portable, handheld pulse oximeters to our huge numbers of migrant workers to monitor twice a day. So I think we all are in agreement that silent hypoxia is really, really quite something that we have to watch out for. And we can intervene quickly and early with a very portable, not an inexpensive pulse oximeter. Finally, we also spoke about hydroxychloroquine, and there was a withdrawal of the big Lancet paper 2 days ago. I've just posted a summary by our ministry, updated yesterday, on the latest, all the clinical evidence on hydroxychloroquine. It's on the chat, you can have a look at it. And we also spoke briefly about the vaccine and the difficulties of the various vaccines, but we do note that the mRNA vaccines and the adenovirus vaccines seem to be doing quite well in the first phase of the human trials. And finally, Alvin brought up an issue of the strike in Hong Kong for sympathy for the new law that they are trying to pass. But I think most of us are in agreement that this is a very difficult time for the population and for the medical world, and a strike at this time is probably not the best thing, to be done at this point in time. Quite a bad time to do a strike. So in summary, I'd like to thank everyone for yet another fruitful session on a Saturday morning. We look forward to seeing everybody next week again at the same time for another fruitful session. Thank you very much.
Thank you, everybody.
Thank you.
Thank you.
Thank you very much.
Thank you.